Six people, every place. Hi everyone, good evening. I'm Harshita from MASH.
Hi.
Hi,
Hello.
Dr. Shalli Bhatta. Hi, Kanika. Good to see you all. Sorry, I'm in the transit, so I'm just using my audio. Hi, Swarnima.
Hi.
Great. We're just also waiting for Dr. Mridu to be on video and we can do a quick mic check for all of you. In the meanwhile, okay, can't seem to unmute. Mridu, you wanna try again? Maybe exit and join again? Be on video and we can quick In the meanwhile, Kanika, do you want to take a minute to introduce Dr. Shalli and Swarnima and probably talk about the panel a bit?
Sure. So I'll just start with introducing myself. My name is Kanika Rajput. I currently work with the Government of India to mobilize private capital into various strategic sectors, including healthcare, education, and renewable energy. Separately, I'm a strong advocate of women empowerment, and I run my own non-for-profit organization by the name of Naftarang, which has impacted about 2,300 girls across India. That's pretty much it. I think super excited to hear all the panelists on their view about women healthcare and probably how better to promote best practices. Looking forward to it. Thank you.
Great, thanks, Kanika. So I see Mridu's also joined. We can do a quick mic check for all of you. I think video is looking good. Oops, Dr. Shalli just left. No worries. I think she should be able to join back. But in the meanwhile, Swarnima and Mridu, do you want to do your mic checks?
Hi, Mridu. How are you? Good to
Hi,
see
Swarnima. Nice to see you here.
Yeah, I'm very glad to see you. And I always love your backgrounds in every panel
Thank
that we
you.
meet on.
Thank you. Tink you. I'm such a book hoarder. Yeah, that's proof of that.
Yeah, that's lovely. That's lovely. I'm currently joining from office, so
Okay.
just a basic whatever window curtain behind me.
I know your office. We'd met you there, right? Yeah.
You know our office. That's
Yeah.
right. Okay.
Right.
So I guess
Hi,
I'm
Harshita. Would be nice to see you too. Nahi?
Yeah,
He's
I'm
right here.
actually.
Acha,
Yes,
Harshita is on. Haan, sorry.
I'm actually in the transit, Mridu, so
Oh.
which is why.
Okay.
But
No problem.
I'll just quickly check with Dr. Shalli. She
Yeah.
seems to be facing some issue.
Hi, Kanika.
Hello.
I'm Mridu Gupta.
Hi, Ms. Ritu. Sorry, I think I did not really introduce myself to you. I think you were just joining in that time.
I know. I was having some trouble with the video and mute, and I just couldn't seem to get it off. So I thought maybe ऐसे ही चुप ही बैठना होगा मुझे. So
No,
now I'm glad
that
I'm back.
it got sorted.
Yeah. Hanji.
So just an introduction about myself. I'm currently working with the Government of India as part of the National Investment and Infrastructure Fund. So professionally, I'm working with the government to mobilize private capital into strategic sectors such as healthcare, education, and renewable energy. Separately, I'm a strong advocate of women empowerment. So I run my own non-for-profit organization by the name of Naftarang, by which I have really tried and connect mentors to underprivileged girls across India. That's about
Wonderful.
it.
Wonderful. You're moderating our session, right?
Yes, that's right.
Yeah. We wait for Dr. Shalli.
Yes.
Something.
Yeah, she was right here. I think there must be some issue.
Yes, she's facing some tech issue. She's just using another device to join. I think she should take another couple of minutes. So we'll wait for her and then we'll go live by 6:15.
Right.
Okay.
So I've got
I
a
thought,
question. Sure. Yeah, go ahead, Nidhu.
no, Swarnima, you go ahead. Go ahead.
No, I just wanted to ask that it says that it's going to be live telecast over Daily Hunt. So
Right.
if we want to kind of circulate this video or something like that, what is the way to do that? I mean, is that
I
an
will
option?
share the link. Yes, I will share the link. Actually the link is generated only when we go live.
Okay.
So I will be able to share that on the chat as soon as we start. And it's also going to go on Mash's YouTube. So you can share
Sure.
both the links.
Okay, sure. Perfect. Yeah. Okay,
Yeah,
thanks.
that was what I was asking you. It tells me that we are already live on YouTube. When I joined, it told me this video is live on YouTube. So is it already live or?
It could be the case, I think.
So I
Oh,
think we'll be
so
chatting up on YouTube live. So please इसको बाद में काट देना.
Yeah, we'll do that.
Free
because
conversation.
oh
Yeah.
my God, okay.
Okay.
Yeah, like in one of the groups in the Delhi Hub group, she has shared also. Oh wow.
Yeah.
I've also shared the Daily Hunt link now. Okay, we also have Dr. Shelly Batra.
Hi, good evening. Am I audible?
Yes.
Yes.
Terribly sorry. This is the third laptop and second phone. After trying all this, I finally was able to connect. So something was problematic from my side.
Okay, I want to share that today my Airtel has also been very erratic. So if I disappear, I will come back again. That is a tech issue that I think ho sakti hai kabhi bhi.
Yeah, this is all going out on YouTube. Just
really.
because
So
we
is
are
there a
live.
link we can share right now?
Yeah.
I can put it on Twitter.
Yes.
Is there a link or something?
Yes, I have just shared a link on the chat. This is the Daily Hunt link. I'm going to share the YouTube link as well.
Could you share the link on email?
WhatsApp?
On email.
Sure.
On email.
Sure. I'll just do that. Yeah. Great. I think with that, we should be good to start. Kanika, over to you. I'll be at the back. Yes.
Thanks, Harsha.
Good luck, everyone. Looking forward to the conversation.
Thank you.
Good evening, everyone, and welcome to a very special panel discussion titled Her Health, Her Voice, Transforming Women's Health in India. I'm Kanika, and it's my honor to be your host for today's event. This evening is not just a discussion, it's a movement towards change, towards a healthier future for the women of our country. We are here today thanks to the collaborative efforts of Daily Hunt, MASH, and CAPT India, who have come together as part of the ongoing Fight HPV campaign. The Fight HPV campaign is more than just a call to action. It's a platform for education, awareness, and empowerment. Through this campaign, we aim to dismantle the myths surrounding HPV, encourage discussions on preventive measures like vaccination and regular screening, and ultimately drive a significant shift in how women's health is perceived and prioritized in India. Tonight, we have an all-female panel of distinguished experts who will share their insights, experiences, and vision for a future where women's health, especially concerning HPV and cervical cancer, is no longer sidelined, but is a central part of our healthcare agenda. Thank you for joining us. Let's begin our journey towards transforming women's health in India. I will now like to pass it on to Swarnima to just give a brief introduction to our audience.
Sure. Hi. So my name is Swandima. I'm the co-founder of Gayatri, which is a women's health platform. And what we do is that we basically provide holistic health support for women's health because we recognize that women's health is not just gynecology, and women's health is not just about, curing some condition or illness that you have, but it's really connected to your overall well-being, your role in the family, your role in the community, your role at the workplace, and how that really affects your physical and mental health, overall well-being, etc. So that's how we approach women's health from a very preventative and long-term care lens.
Thank you. Nidhu, would you like to go ahead with a brief introduction about you, please?
Sure. So I'm Ritu Gupta. I'm the co-founder of, and I lead CAPID, Cancer Awareness, Prevention and Early Detection Trust. We work in women's cancer prevention, largely cervical breast cancer. And now, since we work with the government, we also work in oral cancers. We work with demand generation, which is community outreach, as well as supporting the government to strengthen the health delivery system. We are looking at bringing cancer prevention to the woman in the village, the last house in the village. So that's largely where we work in screening, awareness. And very organically, as we grew over the last 10 years, we have now started doing patient navigation because I'm sure we'll discuss it, the pathway to women's health for a woman to go from the first stage of seeing a doctor to being treated is not well defined in our country. She needs to be navigated through it. So we are trying to help build that system for her, as well as doing advocacy and policy and things like that to improve access for women health. So that's where CAPID is, and we are 10 years old. We have a long way to go, but I'm thankful for platforms like this where, we get a voice and we can bring it to more people. Thank you.
Thanks, Ritu. Dr. Shelley, just a few words of introduction from you would be very helpful.
Well, thank you very much for having invited me for this very, very important panel discussion. I'm an OBG specialist. I've had more than 4 decades of experience in women's health. I'm also the CEO of Every Infant Matters. And our not-for-profit organization is fighting health inequalities at the very last mile in the remotest parts of the country, as well as other countries like Nigeria and the Philippines. We have seen many, many gaps in the health space. And this is why I'm here today, because I believe that together we can bring about a change in the lives of these women who need us now more than ever.
Sure. Thank you so much, Dr. Shelley. With this, I think we are good to go. Let's start with our first question that I would want to throw around in the panel. Really wanted to understand your views and perspective on the current state of women's health in India and the most pressing challenges we face today. And any view by Dr. Shelley? Yes.
Okay, so you see, women's health is becoming more and more challenging because of many reasons. And some of the underwriting factors for the deteriorating women's health are the gender inequalities, the food insecurities and poverty that has come up as a result of COVID, and so on and so forth. With deeply ingrained patriarchy in our systems, the girl child gets the carbohydrates, the rice, and the boy is given the dal, the lentils. And women eat leftovers, women eat last. Everybody knows that. So it's no doubt that more than half of Indian women are suffering from anemia, something that can be treated. And why is our maternal mortality so high? One of the reasons is anemia, because if there's less blood in the body, the more likelihood is there of a woman dying due to bleeding after childbirth. So these are the problems we are facing. Now, when it comes to cancer, I feel that the very first step is missing. If you don't diagnose, you do not treat. Where is the diagnosis? Where is the cancer screening? If you see the latest National Health Survey conducted by the Indian government, the USAID-funded National Health Survey, I think it was 2020, there are parts of India where less than 1% of women have been screened for cancer. And I know my NGO, Every Infant Matters, we are working in Kargil, going right up to the Indo-Pakistan border. And if you talk of mammography and cancer screening and pap smear, people say, what are you talking about? So just recently I was in Kalimpong, and then again we were going right up to the Bhutan border, and there were villages. And in these villages, women did not have access to a tablet of paracetamol for people. There is no chemist shop, things that we take for granted. There is no doctor, there is no nurse, there is no chemist shop. The block medical officer, he came 4 years back for a visit. So where is cancer detection? It's just not happening. So let us think of those people who are living in areas where there is no access to the government health system. Everything is available, but it's not accessible. And that is where the challenge lies. So I'll take a pause here to let other people speak, and then we can take the discussion forward.
Sure. Thank you, Dr. Shelley. Swarnima, if you have.
Yeah.
No, Mridu, please go ahead.
No, Swarnima. Tum bolo, then I will give my
Okay,
thoughts.
so yeah, I think, so firstly, building off of what Dr. Shelley said, that, when we're talking about the state of women's health, it's very intrinsically related to the state of women's everything else, whether it's financial access, access to mobility, access to employment, right? And I also want to zoom out for a second and talk about when we are, healthcare systems globally and also locally. So, Dr. Shelley spoke about diagnosis, right? The biggest problem is that number one, women, there is not enough understanding or awareness of healthcare symptoms. So symptom identification is very poor, at the level of the individual. And this is not just in, women who are in underserved communities, this is across the board. Symptom identification is a huge issue. So whether it is, cancer, gut health issues, chronic health conditions, fertility issues, reproductive health, any of these, the whole spectrum of symptom identification is very poor. Then comes the issue of diagnosis. Now, here there are several factors, right? One is that, because there is delayed symptom identification, therefore diagnosis is delayed. Okay, then in many cases in the underserved communities, in conflict zones and things like that, there is no access. Right. Then there is a very huge thing that we must acknowledge, which is lack of clinical research on women's health overall. So even when women are coming with conditions and they're getting diagnosed with conditions like PCOS or endometriosis or something like that, there is such poor understanding of what these conditions are, what triggers them, what manages them. It is so subjective and so personalized that even post diagnosis, the care system is very poor. So, for example, even if something, like a preeclampsia or something like that, there is such a poor understanding as to what truly triggers it from the, who is more susceptible, how do we prevent that? There is a very poor understanding. And therefore, what happens is that when women go to doctors, then there is a breakdown at the level of diagnosis. Many a time, if the doctors are good, if they they have the time and things, and if they're in private settings, then maybe you can access better care. But most of the time, this in-depth analysis of symptoms and things like that, that is not given. So there is a breakdown at the level of pre-diagnosis identification, then diagnosis, and then even if you are lucky enough to get diagnosed at the right time in chronic conditions, management is very poor. So what happens is then there are questions of financial health and everything that comes with who gets to consider preventative health as an investable opportunity. Most of the time, families don't think of women's health as and as an investable opportunity. And even if they do, it is very skewed towards fertility, maternal health. Even now, in the in the framework of policy and things, we say maternal and child health. Now, while the linkage is, in the sense that, the mother's health has a huge impact on the child's health outcomes, we understand the linkage. But new mothers have an entire trajectory of, health journey, which is not adequately represented in our healthcare systems. So these are all the various systemic things which, where there is, of course, it is rooted in patriarchy. It is rooted in patriarchy that, women do not get to think or talk or address their health beyond the reproductive and the maternal. I'm not even, like, don't get me started on the whole midlife and menopause and post-menopause thing. I mean, that's complete invisibilization systemically. But even before that, fertility and maternity is where the perspectives are skewed. And at the global level, at the systemic level, there is very poor clinical research. And just to give a kind of sense, towards it, that, for example, ED, erectile dysfunction, which happens to, a very small section of men, a lot of, like it has 60% more, funding than PMS, which happens to what 80 to 90% of the women in some form or the other. So there is a lot of, disbalance and imbalance in the way research funding is allocated. It's very gendered and very, it further invisibilizes women's health.
I agree
Thanks,
completely.
Yeah.
I just wanted to add that, there is also a lack of representation of women. In fact, just recently, all of these industry bodies were having their re-elections, and you should have seen the male representation on the board, right? They're largely male. There's not enough women representation, even when we're talking about policies and things like that. So women health gets, like Swarnima was saying, it gets delegated to maternal health. Maternal and child health, that is a tick mark. We've handled women health, right? And even in maternal health, now in India, we only focus on the jacha bacha stage. That jacha bacha stage is where we have all the focus. The woman, a new mother, has mental health, she has nutrition, she needs nourishment. There is so much more that you have to look at. But the whole focus is on this one part of the woman's life journey, right? And a lot of it also is, and we've seen this across diseases and across things in women, is her own lack of awareness. If she is unwell, it goes through her own filter system, you know, कि oh, periods होने वाले हैं, periods हो रहे हैं, अभी periods हुए हैं, I'm pregnant, my mother also had it, my sister also had, menopause है. अगर ये सब चीज she filters out, then she says, oh, something is wrong, I have to see a doctor. Because she hesitates to go also. She's not aware of what she can demand, what is required, what is considered normal, what is not normal. These are things that we need to start talking about. We need to normalize talking about women being unhealthy, or women needing preventive health, or women going to see a doctor. This should be normal. She does not have to show some big superwoman persona, right? You're not well, go and see a doctor. And the doctors have to welcome that. A lot of women's symptoms are dismissed. They are not, like Swarnima was saying, at that diagnosis stage, they don't get diagnosed correctly. So a lot of her symptoms, she doesn't explain them because she doesn't know what is normal and what is not. We have to do a lot. We have to create more awareness, empower the woman, bring representation, policy change, and then make the system available to her. So there's a lot of work, but yeah, at least there's recognition of the fact that that needs to be done. There is a process that we need to build in. So, yeah.
So I will add a little bit to what you have both said. And I just want to say that in my experience, 4 decades as an OBG specialist, I've seen, you have rightly said so. Women do not prioritize their own health. Whether it is the tea garden workers, whether it's a Kambali lady working as a domestic help, or it's the CEO, a hotshot executive in a big company. They do not prioritize their own health. They will delay, defer till things become too difficult and they become complicated. So that is one big challenge. And this mindset has to change. We are important. We as women have to take care of our physical health and mental health, as you've rightly commented upon. So that mindset has to come, that change has to come forward.
It's a very interesting perspective. Thank you, everyone, for these views. We briefly touched upon policies. I think, Mritu, it'll be very good to understand from you, what is your perspective on the current policies that are actually in place to support women's health? And just what future initiatives are planned to address gaps in healthcare access and quality?
So when we look at women's health, the policies, and the fact that we are working on creating those policies, there is a whole area of policy that we need to address. It includes making things accessible, making healthcare accessible to women, but it also needs to include funding and the availability of healthcare for the woman. So when we go through the policy changes that need to be done, it's not just bringing policy and making it available to women. It's because of the gender bias. It is so skewed that we have to overcompensate for a while before we can find a normal zone to come to, right? So it has to be done pro the women, a lot more of policy changes for her, for things to be accessible. So when we go in for policy change, we talk about creating grassroots empowerment for women for healthcare, as well as making funding for her specifically. I know that the government has made the Ayushman Bharat and the other things, but these are family insurance plans, right? Now, what happens in a family is if the husband has diabetes, or there is a heart condition in the family, or the daughter-in-law is expecting or anything is in the family, the woman's health again takes a back seat because it's a family health insurance. We have to have women-centric funding. We have to have women-centric rules. We have to have women representing women healthcare. Breast cancer and cervical cancer is no more a deadly cancer than any other cancers. But women cancers get a backseat. They are not called upon. A woman giving birth has been happening since the beginning of time, hasn't she? We would not all be here if a woman wasn't giving birth. And we still can't get it right. We still can't save her. We lose more women than any other species does. So what is it that we are doing wrong? We're just not prioritizing the woman's health. So policies have got to be women-centric. They have to make her the center. They are not, and also women. They can't be that. They have to be women-centric. And we have to get funding and her specific issues into place, right? Women need support to travel. They don't go for healthcare. They don't have access even to a clean washroom if they go out. I have that problem. If I go to a government office or I go somewhere even to discuss, I have to hold myself for at least 8 hours because I refuse to use any of those public roads, right? So we haven't made this easy for women. How do you make it accessible for her? We've got to look at a lot of things. So policy change have to be women-centric, have to bring women in, have to address all the areas that are barriers for her, whether it's societal, whether it is financial, whether it is, stigmas, things like that, all of them we have got to do. So that's where we are. And there are policies coming in, there are guidelines coming in, but there is still a lot of gap. Again, I said representation is very important. Till we don't have women there to understand women health and to take the lead on this, there will be a gap in policy. So I believe that's important.
Swarnima, would you like to add?
Yeah. So, now in terms of policy, I'll, just segue a little bit into other types of, when we say policy. One is, of course, the policy, kind of attitude that Mridu very correctly put forward, right? That, making it women-centric, right? I think I want to talk a little bit about some policies that are health adjacent that have a huge impact on women's healthcare outcomes. For example, the prevention of sexual harassment at work policy, or things like that, Now, what happens is, or the Disability Act, which, has, which did not, talk in a very in-depth manner about women with disabilities, right? Now, what happens is that when we are talking about health, now what I have seen in all these years is that healthcare is very, it's viewed in a very disease-oriented fashion, okay? And this is even more so in the case of women, and it's even more so in the case of the global majority, right? Because in countries like ours, I mean, we're still, talking about tuberculosis and things like that. I mean, there have been, healthcare has been very associated with, overall public health priorities in general. Now, the problem is that in the public health priorities, because of our, our political and cultural, context, we have fronted and prioritized those conditions which basically lead to death, So if it is life-saving, I mean, it's about a life and death matter, then there is a lot of policy impetus. But what happens is that we don't talk about things like HRQOL, which is health-related quality of life. So, for example, this is something that's a huge lacuna in the way our policy is being framed. Of course, there are improvements. I'm not saying that, even in the Janani Yojanas, like they're talking about, maternal mental health, but it's a very impoverished understanding of how to integrate mental health in the, maternal journey and things like that. So one is that what are the policies that really, are adjacent to healthcare and they're not disease oriented, but they have a huge impact on all factors that affect women's healthcare outcomes. For example, are you able to work? Is your workplace friendly? Like is it, gender friendly and things like that? Are there adequate measures in place for you to thrive at the workplace? Can you talk about, maternal benefits in a proper way? And if you don't have that, then your financial, independence is in question. And let's be honest, as of right now, even women who are financially independent, they don't prioritize. I mean, healthcare is not a priority spending for them. So the more, the less there is dispensable income for women, the more deprioritized, healthcare gets. And if you look at the market trends, that, we can see in the markets, if women have I'm just thinking, like, we see this, that, if you can take a quick, day trip over the weekend and you have to take a pap smear, then most people will choose a day trip with your dispensable income, So this is just how people think in terms of, healthcare. So number one, what are those policies for women, for their safety, for their mobility, for their financial independence that leads very directly to healthcare outcomes? Are they strong enough? And the second thing is that, can we think of policy as not just life and death matters and disease management, but really overall well-being? Because so recently, just because this is March and this is the month for endometriosis awareness, the George Health Institute really came out with a policy outline for endometriosis, and they said that this should be part of the public health policy. Yes, of course. Like, women's health is public health, but we don't think of it that way. So public health discourse is very ungendered, or whatever, gender neutral, or we don't think of it in a very gender disaggregated manner. And coming to that is a third point, that we need to find data systems which really front this gender disaggregation. Now, this is a learning that we have had world over, especially in the aftermath of COVID, that what was the incidence among men and women, what were the recovery rates, what were the mortality rates. We've seen gender differences, right? But the world has now woken up to the idea of gender disaggregated data. Till we don't put this into policy, we will not be able to know how to sort of allocate our resources at what stage or what life cycle of a disease, and save lives or prevent illness and things like that. So these are the three, things that from the policy perspective we can think about.
Super. Thank you so much, Swarnima. I think from my professional experience as well, I think the lack of data and just desegregation of, gender-based data, I think is a huge, huge lag, especially in the government system. Thank you so much for that perspective. Dr. Shelley, would you like to add, please?
Well, Mridu and Swarnima have covered most of the aspects. I would like to add just one small point to it. When we talk of policies for women's health, I see that there is no mention of sexual health, and this is something that's really not touched upon. Either it's due to our cultural background, we are uncomfortable talking about sexual matters, so sexual health doesn't come in the picture at all. But where is the education for the teenage girls? How can they prevent themselves? How can they protect themselves from, say, uh, unacceptable approaches from men? How can they protect their bodies from harm due to, should I say, harmful practices that can happen? How can they prevent cervical cancer? How can they prevent sexually transmitted diseases, unwanted pregnancies? Where are the policies for teenage girls, school children, even older women? There is no one touching on these matters at all. And this, I feel, is a very big gap. It's a very big gap. And I feel that the time has come, governments and policymakers and NGOs, in fact, all of us should get together and make a firm stand that this is where the challenge lies and this is where the work needs to be done.
Thank you, Dr. Shelley. I think you presented some interesting points that serve as a perfect segue for our next question. In the sense, what are those comprehensive strategies that can be implemented to enhance HPV awareness, screening, and vaccination rates among women in India? Would you like to go ahead, Dr. Shelley?
Yeah. So the question is about strategies to prevent HPV infection and, of course, subsequent um, sexually transmitted diseases like warts and cancers and all that. So there are many strategies. And I feel that the biggest strategy here is awareness and education. And that, again, I come to the point of socio-cultural norms. That is where the challenge lies. Now, what we would like to do is that every young girl between the age of 9 and 12, why girls, even boys, they should get the vaccine against cervical cancer. Should they not? 9 to 12 years, even 12 to 15 years, even up to 26 years. The vaccine is important, but you just can't go and give a vaccine. It's not like DPT or polio. You can't say they are polio drops. You can't say that this injection prevents tetanus, because nothing can be given to a child without consent, and the consent has to be taken from the guardian. Now, I'm a doctor. I get a young girl who's, say, 15-year-old in my OPD with some medical problem. And if I want to counsel the mother that before she starts sexual activity, I would like to give her an injection to prevent HPV infection. The mother will start getting upset. What are you saying? My girl is in school. She's not married. You are pointing fingers at my girl. You are, uske charitra par daag laga rahe ho, to make a dramatic statement. So these conversations are not easy. But I still say they have to be done. So, because the biggest strategy here is education, awareness, and dialogue. The time has come to break the silence. As it happened with HIV, you might be remembering decades ago when HIV was new. People were scared to talk about it. And that is how HIV spread. But the day we decided we are going to come forward and speak, break the silence, the problem started getting resolved. And I believe with HPV and cervical cancer, it's the same situation now. We have to break the silence. We have to go to schools, we have to go to meetings, take consent from the parents, the school authorities, and strictly follow government guidelines when it comes to awareness and education. But keep it up. And of course, the government is promoting the vaccination now, and that should be done on a war footing across the country, because cervical cancer is preventable, and if we don't prevent it, it's a shame. And it's a very big fault on our sides. If any girl gets cancer in this day and age, cervical cancer, something that can be prevented, we have to hang our heads.
Thank you so much. Thanks, Dr. Shelley. Ridu, would you like to add? Yes, please.
Yes, absolutely. So one of the areas that is missing is preventive health. We don't talk about preventive health, right? In any health space, it's more about disease management, like Swarnima was saying. It's always firefighting. If you have a problem, you will come with symptoms. Still today, if a woman has to go for screening to any doctor, she could be private, she could be a public doctor, the woman will say, do you have symptoms? If you have symptoms, yeah, I'll screen you, right? So I know that even for breast cancer, October was breast cancer month, and I was interviewing a lady who lost her mother to breast cancer, and her sister, she was going with her sister for radiation, regular radiation, supporting primary caregiver for her sister with breast cancer. She's 42 years old. I asked her, have you been screened? She's saying, no, I have no symptoms. I'm being very careful. You have a history of breast cancer in your family, right? But no one tells you that without symptoms, you need to be screened. So preventive health is something we don't talk about anywhere. We need to make preventive health the focus. Once we start talking about preventive health, then all the areas. I'm telling you today that most cancers can be prevented if caught early. Would you know what you need to do to prevent them? Do you have a comprehensive list of the prevention screenings that you need to do? You're 30 years old, or you're 40 years old, or you're 50 years old. What do I have to do? Where do I have to go? No, we don't talk about preventive health. All our focus, all our funding is on care, on treatment. It's more interesting. It makes more business sense. Preventive is not something you can measure, preventive health. How many women have you prevented from getting cancer? You cannot measure. But how many women got cancer, and how many did you treat, and how many lives did you save is something that's measurable. So nobody gets into preventive health, right? So for one thing, that whole concept of prevention is something that we need to bring in. And yes, if you bring that in, then you need to educate women or everybody. But for cervical cancer, yes, women. You're hale and healthy. You're perfectly fine. You need to go and still see a doctor and be screened. Women don't go till they don't have a problem in their system. And you're talking about screening or taking a vaccine or preventing something. That means that she has to be healthy and she has to get it done before the symptoms show up. So to get her to go and do it needs a lot of awareness. That is where it would come if a woman was aware of it or she was educated about it, she would know that her daughter needs to be vaccinated. It would be an outcome of being aware. Today also the government is talking about the vaccine and they're looking at a school rollout program. But what will happen? The mother will call up the doctor and say, the school is giving this vaccination, should I get it done? Is the doctor going to say, ha, vaccine karwao? What is the framework in our country? What is the protocol? Till now, if the doctors were promoting the vaccine, sabko lag gaya hota vaccine. The doctors are also not promoting the vaccine, right? So if she's going to go back and check with the doctor saying, I don't know, dekh lo, lagana hai, laga lo, free mein hai, kar lo. Those kind of non-confirmatory kind of approach to preventive health, it's something, so it needs to be done across the system. We can educate, we can make them aware, but they need to be supported by the system as well. So that is definitely strategy we need to put in place. And before the vaccine, history from around the world, whether you look at Kenya, Nairobi, even Japan, the vaccine was rolled out. It started well, and then it fell through. They had to redo the whole process, talking about it from a cancer viewpoint. There was a lot that needed to be done. So just rolling out the vaccine does not mean that there will be uptake, and does not mean that we are going to get to a place where we can say that cervical cancer is being prevented. It needs a lot of work to it. So roll out the vaccine, ensure that people are educated, ensure the doctors are on the same page as what the government wants to be said and done. The information should be clear. There should be a unified message. Everyone should be giving one message. Today, we have multiple messages coming out on cervical cancer and about the vaccine and about the screening and karo, na karo, kya karo. One message everyone should be giving. And across the board, from the doctors to the ASHA workers, everyone should be saying the same thing. Yes, that is the strategy that will get us moving in line for cervical cancer elimination.
Thanks, Mridhu. I think you touched upon very interesting perspective with regards to implementation related challenges that absolutely need to be addressed to just bridge this gap, and not just handling it at an upper 30,000 feet higher level by just rolling out an initiative. Thanks a lot. Swarnima, would you like to add to this, please?
Yeah, sure. No, I think extremely kind of, like action-oriented points from both Dr. Shelley and Dr. Midhu. The thing is that, see, what happens is that I completely agree that, so first of all, it's great that the government has rolled out what it has rolled out. But so, I mean, I just feel that when there is visibilization of something from the, central government and things like that, then people at least talk about it, Of course, some people do it sensibly, some people do it by way of gimmicks and all of that, but that's a different matter. But, there is visibilization. It enters our verbiage, which I think is extremely important in the matters of health. Now, the thing is that, so WHO has a bit of a global health strategy for eliminating. So they have said this sweeping statement that, by 2030, we need to ensure that 90% of the girls, are fully vaccinated by the age of 15. And so from the vaccination perspective and from the screening perspective, 70% of women, must be screened using a very high performance test, by the age of 35 and then 45, etc. Now, the thing is that this is all very well that, these things are prioritized and things like that. But what happens with, now I'll tell you how this works, okay? So now when some policy gets made at the global level, then it leads to a bit of a funding push. Now, what happens is that because there's a funding push and because of the way things work, that, that where the money is coming from and where it is getting distributed, what happens is that in the low and middle income countries, this implementation happens in a very, suboptimal way. Now, the WHO has said that, okay, we have to get screening done of this percentage by this age. But look at a country like India, go to any other country in the global majority, where is the access to high image screening? That's number one. Number two, then, again, this is just a psychological thing that, like Dr. Mridhu said, that I'm feeling fine. What should I get, this thing? Like a lot of people actually believe this in the perspective, and I'm talking about, even like urban places, maybe tier 2, whatever. So where I belong, I'm from Lucknow, okay? And I hear a lot of people saying कि जब तक कुछ सर पे आया नहीं हम जाके बुलाएं क्यों उसको? Till nothing is coming knocking at your door, why should I go and, invite stuff, into, this is the attitude towards healthcare. So one thing that we have to understand is that in a country like India, by and large, there is a lot of, there is a spiritual tint given to preventative medicine and healthcare, especially things like cancer. Then there is a reliance on, natural healing and things like that. People, what we consider as screening, prevention, medication, diagnosis, people arrive at that a little late in the day. People think that if I'm exercising every day, doing this, doing that, it's all fine, right? So number one is that when we are making global health strategies, then is that, how far, to what extent is that possible to superimpose on a low and middle income country? Where do we get these, great quality imaging, screening centers and things? And who's going to take the women from point A to that high quality image center? Who will spend the money? Who will take the decision, right? Second thing is that when we need to deep dive a little bit on the way we circulate data around women and healthcare. You will see this in many reports, and a lot of these healthcare experts and women's health experts say that 80% of healthcare decision making is being made by women. Okay. But this decision making is not for themselves, it's for the family, and making decision, that is the, and making decision to allocate funds and doing that transaction, that is not being done by women by and large. That is being done by men. Like even a lot of e-commerce sites these days will tell you that women are browsing and the husbands are paying. Even in e-commerce, like this data is there. This is even more prevalent in healthcare. That, so this data, when we say this becomes, oversimplified data that does the rounds on LinkedIn and other such things, 80% of decision making is being done by, this is non-nuanced data, right? That is the second point. The third point is, as I said, that what are the, cultural barriers to diagnosis? One is this, over reliance on if there are no symptoms, then I will go nowhere. The second thing is, and this is pertinent, especially in the case of cervical cancer, is its relation with sexual activity, right? The moment, a lot of people have come to us and saying that, no, but this is going to be pertinent only if there is sexual activity, but wo to meri beti karti hi nahi hai. Like there are mothers who tell us this, and then we have to tell them that, look, one of the most common ways by which you might get infected by HPV is through sexual activity. It's not the only way. And this is one of the most common strains. And then we have to tell them that more than 80% of the world is infected by HPV at some point of time in their, lifetime. Some of those things, they develop into cervical cancer, etc., etc. Hence the prevention thing. So there is a lot of cultural baggage around what this vaccination means. They think that, why do I need a vaccination? I will simply choose the path of abstinence. That is just the cultural understanding, So therefore, whenever we are thinking of policy, whenever we are thinking of a strategy and things like that, what happens is that we have to do it according to social setting. It has to be extremely context specific. Now, for example, I'll give you a small example. What is healthcare behavior in suburban Uttar Pradesh is very different from what is healthcare behavior in suburban Andhra Pradesh. Then there is a role of religion, there is a role of caste, there is a role of gender. Now, when we are creating policy, if it does not respond to this, nuances of patient behavior or user behavior, as we say, then we have no policy. Then it is just a generalized document which does not have a unified messaging, as Dr. Mridu said. Right? Now, for example, in COVID, we were saying we wash your hands. Okay, this is fair. Everyone can wash their hands or whatever in most cases. But this cannot happen in the case of cervical cancer. And we faced a similar in the public health journey of India. There was a similar challenge for polio, where context-specific messaging was done on war footing, and we got the results, in to the greatest. So we have examples of public health victories out there. Okay. But what happens right now is that global strategy messaging percolates in a very suboptimal way, funding percolates in a suboptimal way, and our own policies do not reflect the huge diversity of behavior and the huge diversity of access in very different settings. So that is something that we must do. And here the role of healthcare practitioners becomes important. We are still a country ki bhai doctor se pucho. public health people, we can do our panel discussions and everything, but the doctor se pucho. So the doctors have to become the advocates. How we do it, in what language, that is what the government needs to do.
Understand. Thanks, Swarnima. Maybe just one last question.
Kanika, very quickly, I just want to add that everybody here, since we work on cervical cancer and the vaccine is coming in, so one line that we say everybody should speak about when you talk about the vaccine is that HPV vaccine is cancer prevention. It prevents 6 types of cancers. And that's all that is important, right? Whether that cancer is transmitted through skin, through sexual activity, whatever is not the point. It is cancer prevention. It prevents 6 types of cancers. Now the country is rolling it out for women, for girls. But once that is over, the boys will also come under the ambit, right? So all girls and boys will be vaccinated because women get more of that cancer. We are starting with women. With girls, we will move to boys as well. But the whole complicating the messaging is where we lose the message completely, right? So we just stick to that HPV vaccine is cancer prevention, and it prevents 6 types of cancers. It's not just cervical cancer, right? So let's promote just that so that people get that vaccine confidence, and when the vaccine is rolled out, they are more able to take that vaccine for their daughters, because the world over it's for boys also. So let's not leave the boys out of this.
Yeah. Exactly.
Sure, thank you so much. Maybe just one last question. Swarnima, Dr. Mridu, you touched upon, very interesting perspective on information consistency. I would like to ask specifically to Dr. Shelley on, since Swarnima mentioned about consistent messaging that has to come from doctors, what is your perspective in the sense? What are the specific strategies that can be implemented to, encourage doctors to really, communicate this messaging that, HPV vaccine is indeed super essential. So
Yes.
just any perspective on that?
Yeah. So first of all, when we talk of doctors, we must remember everyone does not have access to a doctor. The first point of contact could be a quack sitting in the slum. So now when we make policies, we have to include the homeopathy doctors, the Ayurveds. Everybody has to be brought under a common umbrella, and they will all have to be encouraged to give the consistent messaging. The challenge that doctors are facing is that cervical cancer has been linked to sexuality, to multiple sexual partners, to irresponsible sexual behavior. And if doctors themselves feel uncomfortable talking about it, what can be done? So that, I think, consistently the message has to go. And I think the government should have more of these education programs for doctors, not just in the government setup that is happening, but even enroll the private practitioners and all the Unani and homeopathy and Ayurvedic practitioners, that you are getting patients for every kind of problems. And why don't you start with this big project that the government has undertaken of eliminating cervical cancer, of vaccinating so many millions of girls in the next few years? So you all have to be part of it. I think it's only when we all join hands that we can make a difference. Otherwise, I feel that it's the efforts are just a drop in the bucket, a little drop here, a little drop there. So there's not going to be any result. And the other point I want to touch upon is that in the remotest parts of the country, in the mountainsides, on the border areas, the Indo-Myanmar border, Indo-Bangladesh border, there are no doctors there. There are some ASHA workers, there are some Anganwadi workers. Let the message go through them. So a consistent messaging from the tertiary care hospitals right down to the ASHA workers and Anganwadi workers and the local practitioners. Everyone should be included in the system. Only then we can have any kind.
Sure. Thank you so much. I think this has been a very, very helpful discussion, and I'm sure that our audience loved it as well. Maybe as we conclude tonight's enlightening panel discussion, Her Health, Her Voice, Transforming Women's Health in India, I want to extend a heartfelt thank you to our esteemed panelists for their invaluable insights, and to you, our audience. This journey doesn't end here. let's carry forward the momentum from tonight's discussion, armed with knowledge and a renewed commitment to women's health. Together, with the ongoing support of Delhi Hunt, MASH, and CAPID India, we can continue to fight against HPV and work towards a future where every woman in India has access to healthcare and support she deserves. Thank you so much.
Thank you. Thank you
Thank you so much, Kanika. Thanks a lot. Bye-bye.
Thank you.
Bye-bye.
Thank
Thank
you,
you,
Dr. Shelley.
everyone. What a lovely
Bye,
discussion.
Swarnima.
Wonderful
Bye,
to meet
Vidhu.
you.
Bye, Dr. Shelley. Bye-bye.
Bye. Lovely to meet all of you.